Now we'll go for a third case by Dr. Anil Dhal, a patient with multivessel coronary disease and renal dysfunction.
As much as I want to thank... Sure. Thank Srinivas for this opportunity to be here. I must confess that I did not realize that it was going to be a case to present. In any case, all of us every day in the cath lab do deal with multiple cases which come with renal dysfunction. So it was actually, I had a very interesting case, but seeing Sirish's presentations, I thought that there's no point going over yet another syntax 38. In fact, in this particular patient, the creatinine was 3.5, and we chose, as we ordinarily do, we were less brave than Sirish. We asked our surgeons, and our surgeons said that they would operate. So they operated. The patient had a very, it's not just contrast which damages the kidneys. Surgery can also worsen nephropathy. So the patient had a prolonged course on dialysis. He was a diabetic. Came back. He left the hospital in about 20 days. And in about a month and a half, came back with rest angina. I was walking through the ER and I found a familiar face. I said, oh, this guy's been operated. Does he have Dressler's? Why is he here so fast? Looked at his EKG, there was ST elevation AVR. So said, this is not pericarditis and I must know what's going on. Took the patient to the lab. All his grafts had closed and we had no choice. So we had to go ahead and put 7 or 8 stents. And the twist of fortune is that the patient actually did better despite our using limited amounts of contrast, and the only way we could use less contrast was using a lot of intravascular ultrasound to do a non-Indian angioplasty, because routinely in labs which don't have IVUS, what we keep doing is we keep trying to size our stents with a lot of contrast injections. So that was the case. So I must apologize. This is not going to be a case. This is not going to be as challenging. It's more didactic because we all know that contrast nephropathy hurts. And it hurts because we all know the definition. If creatinine increases by 25% or more than 0.3, and the hallmark to remember is that it actually happens 24 to 48 hours post-contrast exposure, peaks 5 to 7 days later, and may normalize in 10 days. And this is the time course of event. Of course, it adversely affects the prognosis, and this prognostic significance by variety of data has been repeatedly shown, including by the recent Poseidon study, which showed that there were increase in major adverse events if there was more contrast exposure and contrast nephropathy. So it is not just contrast which causes this. So does surgery, as I said. And when we use contrast, it is not just an elevation of creatinine. We all know from our reading of Harrison when we studied it for our MDs that creatinine actually rises very late in the course of renal disease. And the kidney injury is to be presumed to occur in every patient that we subject to a procedure using a contrast. Why does it happen? How much does it happen? It is different. The general population risk may be as low as 0.15 to 2.3%, but in a high-risk group, it can be as high as 90%. The good thing is that usually, unlike the standard acute tubular necrosis, here there is a rapid return of renal function. It can happen because of variety of reasons like renal vasoconstriction causing medullary hypoxia, cytotoxic effects, tubular obstruction, tubular toxicity, and oxidative damage. So these are all the changes, and they happen throughout the course of the kidney. So all this it is not just an inspissation of the contrast into the tubules, because in that case the TAM horsepower proteins would have increased. It is not just tubular toxicity, because in that case there would have been a greater amount of potassium leak. It is a mixture, it is a multitude, and it's a different animal by itself. We need to know in which stage of renal disease is the patient in, and we need to have an EGFR. And because CIN is increased when EGFR is less than 60, and for most RCTs, they require an EGFR of less than 60. There are a variety of risk scores, McCullough score, Bartholomew score, Roxana Mehran's score, and all these scores, the simplest possibly is Roxana Mehran's score, where she gives 5 integers for hypertension, use of IBP or heart failure, 4 for age more than 75, 3 for anemia and diabetes, and 1 for each 100 cc of contrast used, 4 for creatinine more than 4, and then with this risk score, determine the risk of dialysis and the risk of contrast nephropathy in every patient. This risk score has been validated. If it's less than 5, both by derivation and validation, it usually causes very little problem, and more than 16, there's a very high probability of both CIN as well as of using dialysis. We must understand that coronary procedures can also have other events, especially cholesterol embolization, and they have a higher event rate in terms of contrast nephropathy than any other form of contrast nephropathy. Whenever we deal with a situation like this, we must rule out blue toe syndrome, and there are classic hallmarks of how we do it. If the patient has blue toes with palpable peripheral pulses, there's some eosinophiliuria, rising creatinine, it is bad news. We can call it chocolate syndrome or cholesterol thromboembolism syndrome. We must also rule out volume depletion and standard causes of acute tubular necrosis and interstitial nephropathy. We can look at some biomarkers, and important biomarkers are like cystatin C. It prognosticates even better than creatinine, and this has been studied repeatedly. There are new biomarkers like NGAL, and this is again, there are a variety of newer biomarkers which are yet being developed, some of which I cannot even pronounce. How do we do it? The best way is to prevent it. And if you look at a case example, if there's a 76-year-old female with diabetes, hemoglobin 11.5, EGFR 36, if we use contrast of 100 ml, CIN risk will be 26% and dialysis risk is 1%. But if we use more 200 ml, the same CIN risk score is more than 16, and now the CIN risk is 57% with dialysis risk of 12%. A lot of possible therapies, and this is just another field where we have tried many, but not a single trial can conclusively say that this works, because every trial has different entry points. It's very difficult to standardize, and it's very difficult to really assess all this. At the center of all these preventive trials has got to be hydration. We understand that, and how hydration works. We have to look at hydration was first compared to urinary flow rates, because it was felt that if you could maintain adequate urinary flow rates, we'll have less renal injury. And this, we tried bicarbonates versus saline at different rates. But in the type of fluid, the volume of fluid, and in whether or not we used N-acetylcysteine, the route and dose all differed in all the trials. In the Prince trial, it was felt that if you could maintain a urinary flow rate of more than 150 ml per hour, it reduces the toxic effect of contrast media. But we all know that if the patient is in cardiogenic shock, we are going to have problems when we do this, and we can achieve this kind of urinary flow rate in less than 30% of patients. So bicarbonates were thought to be preferable because they lead to less volume retention and more volume excretion. But there is no, if you really compare all the meta-analysis, there is no clear benefit of using sodium bicarbonate versus sodium chloride. There were randomized trials like the MENA trial, which was done with using different strategies with bicarbonate and sodium chloride, but it resulted in similar rates of contrast nephropathy. Again, we used normal saline and half normal saline, and although there were a few trials which said that one is better than the other and maybe you could use half normal saline, it really did not reflect on something which can be made into a recommendation. Clavillo actually published in 2006 that if you cannot do anything, you only have an arterial line, give intra-arterial 5% dextrose. And he showed that this also benefits contrast nephropathy, but again, I don't think this is enough for us to make a recommendation. A closed-loop fluid management system called the renal guard system was developed, which was a single-use intravenous set where it could be connected with a console so that you could achieve giving a lot of fluid hydration, and also this was subjected in the remedial trial, giving high-dose furosemide to achieve a lot of urinary excretion. But as you can see again, the event rate at 1 month did not show a real advantage. The same thing was tested again in the Mythos trial, and the study protocol was that there was a continuous infusion of matched replacement saline, and there was IV furosemide about 0.5 milligram per kilogram given, and this achieved a mean urinary output of about 900 cc per hour. And despite this, they said initially that it did decrease the amount of MACE and CKD patients, but we were not sure if this could be managed in every patient, especially those who have LV dysfunction, because the hydration volume should be commensurate to the patient's risk, and you may actually need to do a hemofiltration along with HemoGuard. The unknowns regarding hydration were largely related to the rate, the duration, and can everybody achieve the rates which are required. And the Poseidon study, which was reported in TCT last year, managed to do it along with LVDP assessment prior to contrast administration, and using different protocols depending on the LVDP. And this was an LVDP guided therapy, so that you could stop it if the LVDP rose and did not give more fluids if there was any shortness of breath. And this is the first trial to test the hypothesis of whether this could have a benefit, and this had 59% relative and 10% absolute reduction in contrast nephropathy. It is easily implementable, and it can be used if you really want to. The thumb rule is, whatever you do, hydrate your patients, because dehydration is going to precipitate far more than anything else. What about the contrast media? Are isosmolar contrast media less nephrotoxic than low osmolar? We all know very clearly that the more volume we use, the worse it's going to be, regardless of what contrast agent we use. We all know what is osmolality. It is the concentration of particles in a solution. Isoosmolar is where the osmolality matches that of blood, where hyperosmolality is when it is higher than that of blood. And if you look at all the contrast media, they cause all these changes in the kidneys by increasing the osmotic load, by increasing oxidative stress, by causing vasoconstriction, renal medullary ischemia. But we do not really know very well as to what are the different types of contrast media. A kind of non-ionic contrast is not as frequently used today, but we know that if we classify them, we can classify them by osmolality, by ionicity, by the amount of benzene rings which are present, whether it's a monomer or a dimer, and by the names, and these are a lot of names. And also some people thought that viscosity correlates better with contrast nephropathy, but it has not really been found to be true. Of course, histopathologically, there are differences in endothelial cell culture with different types of contrast media that are used, and this from 9 comparative head-to-head studies, there was a difference in the amount of difference whether we used viscosity and osmolality of contrast media. But just to keep it simple, you can either have high osmolar, low osmolar, or isoosmolar. The Nephric study studied this and found that if you used isoosmolar, you were better off. The CARES trial again looked at it and said iodoxanol is kind of better. It was a randomized 1-to-1 between low osmolar and isoosmolar, and showed that especially in diabetics there was some advantage. The threshold of osmotoxicity was by knowing that mannitol solutions more than 1500 milliosmol per kilogram were definitely nephrotoxic. So as far as the recommendations are concerned, in patients with CKD, either an isosmolar or a low osmolar contrast medium should be used. The amount, a lot of people try to make a formula as to what is the amount. This was Brown's formula. By 5 times weight divided by the serum creatinine should be the contrast dose ratio that should be used. Of course, we know that if we use it for radiological procedures, these have better outcome than we use it for coronary intervention or for cardiovascular procedures which require catheterization. So what are the various drugs? N-acetylcysteine was typically used in paracetamol poisoning. It's also a mucolytic, antioxidant, and it has many pathways of acting by direct scavenging free radicals, nitric oxide mediated pathways, and it's a precursor of glutathione and prevents apoptosis. It can be administered orally and intravenously, and this was first, there was a New England Journal publication in 2000 by Teppel, which said that if you load the patient with acetylcysteine, it works. But if you look at the number of studies globally that have been done for prevention of CIN, the Teppel study was only in 83 patients, but 50% of the studies have been positive, 50% of the studies have been definitely negative. So because there is no right dose, there is no reported basis for currently studied doses except that it had been used previously. The belief that it is useful was because it prevents cisplatin-induced nephropathy. But by itself, IV N-acetylcysteine has side effects, rash, urticaria, pruritus, sometimes you have angioedema, tachyarrhythmia, and it decreases prothrombin time. This was again studied very clearly in the ACT trial, which was a large trial, but there were no renal function inclusion criteria. It was a low-risk population. The hydration was not standardized. Contrast was not standardized. And time of serum creatinine dose after contrast exposure was not standardized. Statins have been used, and there are some trials which are now available, including one which was published last year in Circulation, which says that patients who are on statins do better. There's a catheter called the benefit catheter, which has come from Flow Medica, which can be used to actually remove the contrast from the kidneys when procedures go on, and this realizing that the dopamine receptors in the kidneys may have a role in vasodilating the kidneys. Phenoldiprem was tried, but the contrast trial did not show any success. So then thereafter phenoldiprem intrarenal injections were tried without success. What about renal replacement therapy? You can remove it by hemofiltration, and hemofiltration can also be part of the treatment, and this can continue to be used. So just to conclude that contrast is toxic, there's no regulatory limit, and it is inappropriate to use more contrast than is required. So we can now look at some new therapies which can prevent it. There is a new trial called the PRESERVE trial, which is very complex by placing a catheter in the coronary sinus, partly occluding it and aspirating this from the coronary sinus during contrast injection. And this is how the Syncor works. And this can decrease the amount of contrast which remains in the body. A new contrast media itself is coming. There's a contrast medium called Veropaque, which is actually a cyclodextrin, and it is safe when given intravenously. And this, in the animal model, has been shown to block kidney damage, and there is a reduction in pathological scores, and full kidney function, at least in animals, is retained with Veropaque. Phenoldiprem, diuretics, mannitol, aminophylline, hemodialysis, endothelin antagonists, calcium channel blockers have all failed to provide definite benefit. So the future can be angioplasty without contrast, or at least lower limb angioplasty can be done with a carbon dioxide injector. We must use more IVUS to actually prevent use of more contrast. To conclude, it is still a frequent source of acute renal failure. There are multiple validated risk models. We need to prevent, not treat. Hydration and limiting contrast are the most important thing. Stop nephrotoxic drugs. There's very little dose role for N-acetylcysteine, IV phenoldiprem, sodium bicarbonate is probably not useful. Lower osmolar agents are better than high osmolar. Isosmolar, there is no definite evidence, there's no powerful evidence that isosmolar is superior to low osmolar in protecting against CIN. I thought it was a question-answer session. So if there is a question, if there's a 70-year-old male diabetic being treated with metformin, creatinine 1.5, elective PCI, what should you do? Stop metformin, pre-medicate with hydrocortisone, proceed with PCI, induce forced diuresis, none of the above, both 1 and 2. A. So the answer is actually, the answer is D, which is none of the above. You can go right ahead. So the following treatment have been proven to be useful: hydration with saline, with furosemide, with phenoldiprem, bicarbonate, N-acetylcysteine, and the answer actually correctly is with saline. Which of the following treatments is true? and this is phenoldiprem affects both medulla and cortex. The contrast media volume is single most important risk factor. N-acetylcysteine is a vasodilator. High osmolar is safer, and the answer clearly is A, that phenoldiprem affects both medulla and cortex. Thank you very much for your patient listening. I know you were expecting a case and very dramatic things to be happening on the screen, and this was more didactic. I thank you for your kind attention.
Thank you. Any questions from the audience?
Those patients who are going for renal transplantation, they have been routinely advising for coronary angiogram before the renal transplantation, and where the GFR is around 10-15. So what should be the strategy for doing the angiogram of that patient?
Just hydration. Just hydration, use isosmolar or low osmolar contrast, minimize the contrast that you use. In fact, coronary angiogram may not be essential if you have done a good stress echo and you're reasonably confident, unless it's a high-risk group. I know that some of them, in transplant teams have a protocol. They want to identify how many renal arteries there are, and many of them are doing actually CT angiograms, but it should be remembered that CT angiogram needs about 100 cc of contrast, whereas a catheter angiogram can be done with much less. So hydration, what Sunit is saying is that the patient is already going to receive a renal replacement therapy, but why worsen till such time he goes on for it? So that point is taken. You protect it like any other patient. Diagnostic procedures don't harm us as much as therapeutic interventions do.
When you plan to stay multivessel PCI in a patient with renal dysfunction, what will be the approach? What will be the duration between these procedures you keep?
I didn't follow the question. Okay, the one thing which I do differently, certainly, and I'm sure everybody here does the same, is choosing antiplatelets, because this is one clear place where if there are no other contraindications, possibly Brilinta scores an advantage over prasugrel and clopidogrel in patients who have renal dysfunction. Other than that, try and limit the contrast use, hydrate the patients for whatever it's worth. Unfortunately, I still use N-acetylcysteine because hospital managements think that you've not done enough if you don't use it, but I won't give it as a recommendation. If you review the literature, I don't think there is any role of giving so much of N-acetylcysteine as we do. All the patients during an intervention are usually on statins, so that itself is renal protective. Limit the contrast, use isosmolar or low osmolar contrast, limit the contrast that you're using, be very liberal with using IVUS, and do not do a lot of balloon sizing before we put in our stents.
What is the time gap you keep between the procedures?
See, if you have to have a gap, it has to be more than 72 hours. And this is what we don't really realize, because if you do a procedure within 72 hours, suppose you say, today let's give less contrast and let's do a case tomorrow, it's not fair. You're probably just increasing the contrast burden. For complete excretion, you should wait at least 72 hours.